Welcome back, dear students. Now, in the previous session, we saw what is meant by diabetes mellitus. When do we say anybody is having diabetes mellitus? It all depends upon the fasting blood glucose level. If it is more than 126 milligrams per dl, we call them as having diabetes mellitus. We'll go further. How is diabetes mellitus classified? Now, classically, diabetes mellitus has been classified as primary and secondary to other diseases. Primary DM involves type 1 DM and type 2 diabetes mellitus. Secondary to other diseases could be due to any other condition like maybe destructive pancreatitis, maybe there is another endocrine disease like Cushing's or hyperthyroidism, or maybe it may be drug induced where some drug has been given and this has led to the loss of pancreatic beta cells. In all these cases, what is happening? There is elevation of the blood glucose. Minute it is hyperglycemia, we are going to say that it is diabetes mellitus. We have only one condition for that. We don't look at the insulin levels, we don't look at anything. Diabetes mellitus means it is elevated blood glucose. Now the reason could be primary and secondary. As you have seen, there are so many endocrine causes in which we can see diabetes mellitus, that is hyperglycemia. But now we'll focus on the primary causes for diabetes mellitus, the type 1 and the type 2 DM. What do we mean by that? So let us look at type 1 diabetes mellitus. What is type 1 diabetes mellitus? What was it formerly called as? It was called as insulin dependent diabetes mellitus. Why? These people were dependent on insulin for their treatment. So that was the older name, IDDM. Nowadays the accepted terminology is type 1 DM or type 1 diabetes mellitus. What's the age of onset? The age of onset is usually for these type 1, it is between childhood to puberty. So very young kids, maybe around 10 years, 12 years, 14 years, that is when these people can develop diabetes. Usually, we are talking of usual prevalence of type 1 diabetes. What is the prevalence? Nearly 10% of the diagnosed diabetics are type 1 type. Now, what is a genetic predisposition? Moderate. We say it is moderate. What is the defect? Beta cells are destroyed. Why are they destroyed? And what will be the effect? When beta cells are destroyed, there will be absolute deficiency of insulin. Insulin is completely absent. That is why the name insulin dependent diabetes mellitus. Now this is usually caused by autoimmune attack on the beta cells. Autoimmune, the cells, the immunoglobulins are not able to recognize between self and non-self antigens. They think that the beta cells are non-self and they go and attack the beta cells and lead to autoimmune destruction of the beta cells, leading to absolute deficiency of insulin. Now usually it has been seen that in type 1 there is insulitis, that is there is infiltration with T lymphocytes. The cells are infiltrated. T lymphocyte infiltration is there. We call it the term insulitis. What is the reason for this? It could be environment plus a genetic determinant is been implicated in type 1 diabetes mellitus. Now, what is the main symptoms? The symptoms usually suddenly appear, develop very rapidly, and there is abrupt onset. There is no clear something which is going to tell now it is going to start. No, there is abruptly they appear and they develop very rapidly. What are the main symptoms? Polyuria, polydipsia, polyphagia. These three are considered as the cardinal features of diabetes mellitus, especially type 1 diabetes mellitus. Plus, they will also be having fatigue, weight loss and weakness. All these are the characteristic features of type 1 diabetes mellitus. These type 1 people are more prone to complications, and one of the biggest complications that these people can get is diabetic ketoacidosis. So now let us see what is the reason why these people have polyuria, polyphagia, polydipsia. What is the biochemical basis behind it? Why these people are developing these symptoms? So if we look at the biochemistry behind it, so what is happening? Insulin is decreased. We said that there is absolute deficiency of insulin. So what will happen? It will lead to decreased utilization of glucose in the extrahepatic tissue. Remember, insulin is required for glucose transporter 4, and this is in the extrahepatic tissues. These gates, the glucose transporter 4, have to reach the plasma membrane. Only then can glucose enter these tissues. So there is decreased utilization of glucose by the extrahepatic tissues. So what plus what? Decreased insulin will lead to increased gluconeogenesis and glycogenolysis. Where is this happening? In the liver. In the liver, it causes gluconeogenesis. It also increases the glycogenolysis. So whatever glucose has been stored is going to be broken down, glycogenolysis, and plus whatever is there, it is going, whatever amino acid, whatever substrates are there, lactate, alanine, everything are going to be used in the synthesis of new glucose. This is the effects of insulin. So whenever there is decreased utilization plus there is increased gluconeogenesis, both of these will contribute to the increasing the blood glucose. Hyperglycemia. So one characteristic feature, as I said, is hyperglycemia. So if there is hyperglycemia, what will happen? So what? So when the blood glucose level increases more than 180 milligrams per dl, what will happen? It will start appearing in urine. What do we call this condition? Glycosuria. So now we have hyperglycemia more than 180 leading to glycosuria. So what? It will, glucose is having a osmotic effect. It won't just go into the urine. Along with it, it will call something else. What else it will call? It will call water. It is that osmotic effect is there, glucose. So because of that osmotic effect, water is dragged along with glucose. So what? It will mean more urine formation. So what? Polyuria. So these people have polyuria. Okay, fine. They are having polyuria because glycosuria is there. One glycosuria plus polyuria. So what will happen? If water is lost from the body, what will happen? It will lead to increased osmolarity of the plasma. Osmolarity increases. So what? This will lead to stimulating the thirst center within the brain. When the thirst center is stimulated, what will happen? He will start drinking more and more water. Polydipsia. Polydipsia means drinking more of water. Polydipsia. So we have polyuria, we have polydipsia. Now let us see what else is happening. Now we have got insulin is decreased. So what will happen? Remember, the brain is not dependent on insulin for the entry of glucose. It has glucose 1 and glucose 3 are present in the brain. So the whole of the brain is absolutely independent of insulin concentration. So anything can happen. If insulin is low, what will happen? Nothing will happen. Brain is still going to utilize glucose. Brain is going to keep on working. This is true for the whole of the brain except the satiety center. Why is the satiety center insulin dependent? The whole of the brain except the satiety center. Now what is happening in the satiety center? Why it should be insulin dependent? Remember, the satiety center is the center which tells you when to stop eating. It gives you a feeling of satisfaction. So to get this feeling of satisfaction, when should you get it? Only after you have eaten a meal. This fast feed cycle, during the fast feed cycle, after you have fed yourself, only then there should be a feeling of satiety. So what does the body do normally? So whenever blood glucose level increases, insulin increases, and this insulin will act on the satiety center, and then glucose enters into the satiety center. Once glucose enters into the satiety center, the person is satisfied and he gets a satiety. He feels, okay, I have eaten enough, let me stop eating. So this is what is happening. Now when insulin is not there, the satiety center is not inhibited. The satiety center will not understand whether it has got glucose or not. That glucose is not able to enter into the satiety center. So what will happen? He will keep on feeling that he has not eaten. So what will it lead to? It will lead to polyphagia. The person will keep on feeling hungry and will want to keep on eating. This will again contribute to the hyperglycemia that is seen. At the same time, when there is decreased insulin, what else is happening? Insulin is required for protein catabolism. So when there is decreased insulin, it will lead to increased protein catabolism. It is required for protein anabolism, that is protein formation. Insulin is required. So when insulin is not there, it will lead to protein catabolism. That will increase. If protein is broken down, what will happen? We'll see about it. What else will happen? It also has an effect on lipid metabolism. So hormone sensitive lipase is going to be affected, and this will lead to increased lipolysis. Hormone sensitive lipase is going to be activated, and it is going to lead to lipolysis. So at the same time, all this will lead to fatigue, weight loss, weakness. All these are the characteristic features of insulin, or what do we call as diabetes mellitus. So insulin has led to even this fatigue, weight loss, weakness. All this will also again contribute to the polyphagia that is seen. Lipolysis means increased free fatty acid. Free fatty acids will increase the hepatic output of ketone bodies. These people are more prone to ketoacidosis. So these are the characteristic features which can be seen in type 1 diabetes mellitus: hyperglycemia, glycosuria, polyuria, polydipsia, polyphagia, fatigue, weight loss, weakness, and they may even end up in diabetic ketoacidosis. So let us look at the biochemical findings that you can see. Hyperglycemia is seen. That is a natural thing. Diabetes means more than 126 milligrams per dl. Plasma insulin may be low or even absent. Ketone bodies will be present. Triglycerides will be increased. So what is the type of treatment that can be given? Usually exogenous insulin is what is recommended for type 1 diabetes mellitus. Now we go on to type 2 diabetes mellitus. What will be happening in type 2? Now this was formerly called as non-insulin dependent diabetes. That meant to say these people were not dependent on insulin. Something else could be given, and which could increase the release of insulin from the pancreatic beta cell. So let us NIDDM. Age of onset was usually more than 35 years, and this is the most commonest type of diabetes mellitus. 90% of the diagnosed diabetics are of type 2 type 2 diabetes mellitus. Genetic predisposition is supposed to be very strong for this, and type 2 diabetes mellitus is supposed to run in families. And what is a defect? It is a combination of insulin resistance and dysfunctional beta cells. So there is a combination of insulin resistance and dysfunctional beta cells. Whatever beta cells are there, they are dysfunctional. And suppose they are functional, little bit, they release insulin. This insulin is not able to act. Why? There is insulin resistance. So because of both these, what will happen? It will lead to severe symptoms of diabetes mellitus. What is the cause? It is supposed to be both environment and genetic determinant. Both environmental and genetic determinant. Now, what is the reason for insulin resistance? Now, they say that obesity is the most important cause for insulin resistance, and this may be because of the different hormones that are released by the adipose tissue during obesity. These include resistin, leptin, adiponectin. All these have been implicated in having a role in insulin resistance. When do we say anybody is obese? Is when his BMI is more than 30 kg per meter square. And other things include physical inactivity. And what is the cause for dysfunctional beta cells? Because it fails to secrete enough insulin. So these are the causes for type 2 diabetes mellitus. What will be the biochemical findings? Hyperglycemia. Naturally, it has to be there. Plasma insulin will be high early in the disease, but later on, when the disease is of a longer duration, the plasma insulin levels keep on falling. Why? Dysfunctional beta cells. Triglycerides are increased, and one of the acute complications that can happen in these people is hyperosmolar coma. The blood glucose level keeps on increasing, and it can lead to hyperosmolar coma. This is, if you compare it with type 1 are more prone to diabetic ketoacidosis, whereas type 2 are more prone to hyperosmolar coma. What is the treatment? Different drugs are there. Diets is advised, exercise is advised, and the oral hypoglycemic drugs. I'm not going to go into the details of these oral hypoglycemic drugs because that is a part of pharmacology. So they will be talking about these different oral hypoglycemic drugs. What's the basic thing? These hypoglycemic, you can take them through the mouth, oral, hypoglycemic, because these will lead to either the release of insulin from the whatever beta cells, help in the release of insulin and thereby decrease the blood glucose. So hence that name oral hypoglycemic drug. Sometimes later on, as the disease progresses, these people may also require insulin. Some of them may become dependent on insulin. So insulin plus or minus. What are the long-term complications of diabetes mellitus? So this is characterized by what is we basically call it. I'm giving a brief overview. Long-term complications can be macrovascular complications or microvascular complications. Macro means bigger vascular vessels as such. Microvascular is at the smaller level, and macrovascular complications include stroke, cardiovascular disease, atherosclerosis. Microvascular, retinopathy, nephropathy, neuropathy, all these pathies are because of the microvascular complications. There may be a lot of overlap between all this. What is the important thing is, why do these things happen? What is the cause for these complications? They all say it is because of the hyperglycemic effects. It is all dependent on blood glucose level. If somebody is able to control his blood glucose level, he may not end up getting either any of the complication. So it is basically dependent on the hyperglycemic control. How good they are at how good a patient can control his blood glucose level. The key to whole diabetes mellitus treatment lies in blood glucose level maintenance, controlling the blood glucose level. What will happen if blood glucose is not controlled? It can go into alternative pathway. One of the commonest alternative pathway is the formation of sorbitol, and this is because of the enzyme aldose reductase. Aldose reductase and sorbitol formation have been implicated in most of these complications. So let us go to the laboratory investigations that can be done in diabetes mellitus. Urine testing, yes, for glycosuria, but this is usually used as a screening test. Benedict's test is used as a screening test. So, and plus nowadays we have got what are called as dipsticks. Dipstick for urine will just show whether glucose is present or absent. But this does not help in the diagnosis of diabetes mellitus. It just helps to screen a mass population for diabetes mellitus. Blood glucose estimation is the required test that has to be done for the diagnosis of diabetes mellitus. Without doing blood glucose estimation, one cannot tell anybody is having diabetes mellitus or not. So it forms a cornerstone investigation for diabetes mellitus. Next we have got what is called as glucose tolerance test. I will be talking about this glucose tolerance test, which we call it as GTT. Fasting lipid profile. Why do we need to do it? Because insulin has its effects on the different lipid profiles. So to look at atherosclerosis or non-atherosclerosis, to look at the complication, we need to do the fasting lipid profile. Fasting lipid profile includes total cholesterol, serum triglycerides, LDL cholesterol, HDL cholesterol, and plus so many other calculated values are also there. TC-HC ratio, lipoprotein A, etc. are all a part of this fasting lipid profile. Glycated hemoglobin is another important investigation that is done in diabetes mellitus. I'll be talking in detail about all these lab investigations, so please look at it. Microalbuminuria is also another investigation that needs to be done, especially in case of nephropathy. If we want to detect early cases of diabetic nephropathy, microalbuminuria is done. So out of all this, fasting, I'll be talking about the glucose tolerance test, glycated hemoglobin and microalbuminuria. Remember, urine testing is mainly by using dipsticks can be done or by Benedict's test. Can blood glucose estimation, how do we do it? Either by using glucometers or drawing the blood with sodium fluoride, and this is estimated fasting plasma glucose or postprandial plasma glucose. In today's labs, the plasma glucose levels are what are estimated. The methods are very specific for glucose. The enzymes that are used is glucose oxidase. Glucose oxidase reacts only and only with glucose, and it results in the formation of a chromosome which can be estimated. So blood glucose estimation involves glucose oxidase. Then I'll talk about it, and I told to you already about fasting lipid profile. In this, LDL is the one which is calculated, the rest of them are estimated, including total cholesterol, serum triglycerides and HDL cholesterol. Always remember that even lipid profiles have to be done in the fasting state, 12 hours fasting. These people are, whatever blood is drawn into two tubes, one for glucose estimation and one for fasting lipid profile. So in my next session, I'll be talking to you about oral glucose tolerance test. Thank you.